Hello, my name is Klaus Monicke, and I'm professor of pediatric endocrinology at Children's Hospital Otto von Guericke University Hospital in Magdeburg in Germany. And I'm joined today by Jeanette Lagaré, a clinical professor in the Department of Pediatrics at the University of Wisconsin in the USA. Welcome, Professor Lagaré. And by Karen Blakemore, Professor of Gynecology and Obstetrics at Johns Hopkins Hospital, also in the USA. Welcome, Professor Blakemore. In this section, we will considering the question, how can we plan the multidisciplinary management of achondroplasia, incorporating appropriate specialist referrals more effectively? I think it is necessary to start with the burden of illness, which is in achondroplasia. And Professor Lagaré, can you explain your view on this burden of illness in achondroplasia?
So with achondroplasia, it is not simply that patients are short-statured, but they also have disproportion, which means they have shortened limbs, so short arms, short legs, and that makes reaching things more difficult. This can impact quality of life with being able to do things. Achondroplasia is more than simply disproportionate short stature. There are medical sequelae that result because of which bones are affected. There can be foramen magnum stenosis that requires surgery in the neonatal period. There are many ENT issues, including ear issues and sleep disordered breathing, such as sleep apnea. There can be leg bowing and sleeping issues. So I believe that it is very important to have a multidisciplinary approach.
Yeah, I think this is very important that you should explain the families what they expecting, and I will start with Karen Blakemore because I think you are the first one when a family is confronted with the situation that the infant, which they are waiting for, is in a different way not what they expected, and I think this is a very important point that you are can explain what are the special situation for this family and how we can go forward that they have a good delivery and the next steps after delivery.
Yes, with the achondroplasia, thank you. There is more and more prenatal diagnosis happening for babies that have achondroplasia. About 2/3 now in developed countries are being diagnosed prenatally. That being said, they may not present to the eye of the maternal fetal medicine specialist or the radiologist in the second trimester of pregnancy, but more so in the third trimester of pregnancy, because they are on the milder end of the spectrum of skeletal dysplasia disorders as far as the degree of bone shortening, and certainly the much lesser degree of problems with the thorax or the chest. So when we see these fetuses in utero, we approach the patient with the fact that we see something and do go on to prenatal genetic counseling, because it is relatively easy to affirm a diagnosis and not leave a patient wondering what is the diagnosis using today's genetic technologies. So from there, their questions are immediately forthcoming, and we immediately engage with our pediatric subspecialists as well as our neonatologists to try to get those patients appointments in a timely fashion for consultation with those individuals that would be taking care of a child who has achondroplasia. They often have questions about the obstetrical management, and the obstetrical management is really fairly normal from diagnosis to delivery. Although I do mention to them head size, and often we'll monitor that and see if we can accomplish a vaginal delivery if that's desired and the is possible to be done. But we always would refer so that they know where to go once the baby's born through the skeletal dysplasia center, and then from there the multidisciplinary approach that is so valuable to these families. So perhaps I could ask Professor Laguerre how the referral pathways work once a patient is seen in the skeletal dysplasia center.
So every center is a bit different, but we tend to have multidisciplinary care involving neurosurgery, sleep medicine, ENT, orthopedics, and genetics. Different systems may have different multidisciplinary care. Primary care physicians can refer to genetics and orthopedics, and sometimes pediatric endocrinology. It really depends on who in that area is the primary manager for patients with skeletal dysplasias. But I think throughout the lifespan, it is important that multiple disciplines are involved because different medical sequelae arise at different times.
Perhaps I could ask Dr. Moniker, in terms of ENT, the ear, nose, and throat specialists, in what respects they are valuable to the children as they're growing up?
Yeah, I think this is very important because this is really something which almost 100% of these children are suffering. So, also the anesthesia in these children are very special. So I think if they have a very experienced ENT physician, then they can decide when it is necessary, for example, for partial tonsillectomy or to applying ear tubes or this. And also they can talk to the sleep lab and can see is there now a need for surgery because you have a lot of apnea, and this can be decided together when they discuss this child. And in most cases, I think we need at one of the first 2-3 years such a surgery. So I think it's necessary to get this information as early as possible. In the past 30 years ago or so, this was not really looked for very carefully. And a lot of these individuals have to have ear aids now because the treatment in the JAWS was not good enough. And now we can avoid this situation when we really have these ENT people, very experienced ENT people included in our team. I think one of the major problems we heard is the foramen magnum compression, and I think families know that there's a time where they have to be very carefully to look for this compression and to have the neurosurgeons also on their side. We in Germany, we now started as early as possible with an MRI. Is this the same in the US, or what is your approach for this complication?
Yes, we do neuroradiology. Most of the time, this is MRI, and we try to do it as soon as possible. And we also obtain infant sleep studies, because the neuroradiology can tell you how it looks, but then the sleep study tells you how it's functioning. And if you're having any injury or physiologic effects at that brainstem, that's affecting how the baby's breathing.
Yeah. I think for us, it would be very good to have these kind of techniques really compared between the centers, and we used also the AFMS score from the British group. I think it's the same in the US.
We use less of the scoring system. We use the scoring system that the British group detailed in a lot of research, but in clinical care, we get more descriptions of what is seen that, to be honest, is easy to then translate into that scoring system. But there are so many centers that there is no consistency in how they score them here. But for research, yes, we are definitely using more of that foramen magnum score.
Yeah, okay. So thank you, Professor Legar and Professor Blakemore, for your views on this multidisciplinary treatment management, which helps these families in these special situations.
Hello, my name is Janet Legar, and I am a professor in the Department of Pediatrics at the University of Wisconsin in the USA. I am joined today by Dr. Klaus Monika, a professor of pediatric endocrinology from Germany. Welcome, Professor Monika. And I'm also joined by Dr. Karen Blakemore, a professor of gynecology and obstetrics at Johns Hopkins University in Baltimore, Maryland, in the USA. Welcome, Professor Blakemore. And we are joined by Ms. Carly Kuntner, the parent of a child with achondroplasia from New Jersey. And we really look forward to hearing her story and contributions. Thank you for being here today. In this section, we will be considering the question, why is early recognition of achondroplasia so important in reducing the risk of pediatric complications? So the first thing we were going to discuss is prenatal diagnosis. And this might be a good option or section for Dr. Blakemore to take.
Yes, that's definitely the case. Part of this is how often ultrasounds are being utilized in the third trimester, which is increasing. And achondroplasia is a diagnosis that more often than not is not made until the third trimester of pregnancy. But today, approximately 2/3 of the diagnoses do emanate from the in utero period prior to birth. And it is an opportunity for parents to gain information prior to the birth of their child, and for referrals and a referral pathway to begin prior to the birth of the child.
Can you elaborate on how you approach prenatal diagnosis, and how do you talk to families when they have a child diagnosed with achondroplasia?
when the diagnosis is clear, we generally will take it one step at a time, taking cues from the patient as to what types of questions they're asking. I usually start with the obstetrical management, which comes to be fairly routine. We talk about watching the head size to see if the patient desires a vaginal and is a candidate for a vaginal delivery, so that can be accomplished once the baby's at term. The other questions that inevitably start to arise, if they don't arise right away, we usually will address what we can and then refer immediately to the experts who are caring for the individual with achondroplasia postnatally to address a series of questions, complications that might occur. And I think the most important thing is to assure them that there are answers out there and there is a support system that will exist to them as they go forward.
And Dr. Blakemore, do you talk about the new treatments and medications that are approved to help with growth in achondroplasia?
We do. We touch on the surgical treatments for some of the complications, but we always now will let the parents know that there are medical therapies available. A medical therapy is available in the United States, and it is something that many of the couples are going to be very interested in at least hearing about. It is not something that's done prenatally, so they do have time to sort of acquire this information and talk to people about the ins and outs of actually getting the medication down the road.
Thank you. And Carly, can you please tell me more about your prenatal journey?
Sure. So I'm sorry, it was my second pregnancy. I have an older daughter, and so this was my second pregnancy. I was about 28 weeks pregnant, and it was at that ultrasound at my regular OBGYN that the technician had discovered the shorter length in the femur bones, and that led us to then a high-risk specialist. And about maybe 2 days later, we went there. And then I was given another ultrasound. And then from there, I was sent to a hospital, to a maternal fetal medicine doctor. And then that's where we had 2 days really of every test imaginable. And during my extreme testing at the hospital, they knew it was a skeletal dysplasia, but it was identifying which type, which was what they were, unable at that time to really decide on. So it was at the end of the 2 days where all of the doctors came together, and their diagnosis originally was unfortunately a lethal form of dwarfism. By this point, I'm about 30 weeks pregnant. And they said the only way to tell for sure was an amnio. So I'm almost at delivery stage when the amnio results came back. And fortunately, those were that it was achondroplasia, which was a huge relief for all of us.
Wow, thank you for sharing that with us, Carly. Professor Monica, can you explain why early diagnosis is so important?
Yeah, I think one of the major complications, which are not so frequent, but they are major complications, is a foramen magnum stenosis. And we need first to educate the families that the cervical area is a little bit sensitive. So, for example, if you have this child in a car, then you have to put it in a certain direction. I think Carly will will confirm this. So from all these complications, we need to have these that parents are knowing what is the risk. And the second part is we should do diagnostic steps like sleep lab, like the clinical investigation, and like an MRI. And I think this is something which is recommended now, but we have to do it. And we also have to know that when we didn't know about the cervical part, then it might be something which can be have danger for the child.
Thank you, Professor Monica. So I'm going to briefly discuss the age stratified management, which means that there are different specialists who are involved in the care of patients with achondroplasia throughout the lifespan. During the first year, we really are concerned about that foramen magnum stenosis. So neurosurgery is frequently involved. Sleep physicians are frequently involved because we are looking and interpreting sleep studies in babies to see if there is any compression at the foramen magnum area. As we go through toddler and preschool years, ENT issues become much, much more common. And it can also start affecting obstructive sleep apnea or causing obstructive sleep apnea, such as increase in size of the tonsils and adenoids relative to a small back of the throat and back of the nose. So ENT stays involved frequently throughout entire childhood. And orthopedics also becomes involved because of leg bowing. And frequently we have other therapists like physical therapists or occupational therapists involved.
Yeah, and I agree also with the spinal surgery. I think this is also in this age period. Yeah.
Yes, spinal stenosis is the most common morbidity or complication in adults with achondroplasia as well, and that becomes more and more of an issue in adolescence. Would you care to elaborate on that, Dr. Monica?
Yeah, I think we now discuss it is necessary to make an asymptomatic child with achondroplasia already diagnostics maybe at age 8 or 10 years, and then we follow them clinically, and then maybe at a later point it is necessary to repeat this.
Thank you. Carly, could you elaborate on any complications that your daughter had?
Sure. So within her first year, she did great up until about 9 months. We were concerned that she had no head control and was doing kind of strange, like back arching, and she did have sleep apnea, obstructive sleep apnea, which we found out after our sleep study. She's had about 6 or 7 in her lifetime. Again, she's 7 years old. So at 10 months, she did actually have an emergency foramen magnum surgery because, and it's funny that you brought up the car seat earlier. We had an incident at about 10 months old where she was in her car seat, perfectly placed, rear facing, and we were driving home from my other daughter's dance recital, and the position of her head had fallen to her chin, which led to her stopping. She stopped breathing. And thankfully my husband was cool under pressure and performed CPR on her and saved her life. And it did turn out, we found out 2 days later that her spinal column was being crushed so tightly that she was not able to get air in. And the day after that incident had happened, we were at a different hospital than the one she was born at, and they took one look at her and they sent her in for an MRI, and they discovered this, that how tightly that opening was, and then the next day she had that surgery. At 18 months, she had tonsils and adenoids removed, and this was as a result of that sleep apnea. And that seemed like a walk in the park after what we'd been through at 10 months old. So she had the tonsils, the adenoids, and then a few months later, she had those ear tubes put in. And so those have been put in, taken out, put in a few times. So those are the surgeries she's had so far.
Thank you for sharing. How much did you want to hear prenatally when your daughter was diagnosed with achondroplasia? How many of those complications did you want to hear? Or would it have been better for you to only hear about the things early on? Because, I think we can all learn about what's best, from patients telling us.
It's a very, very good question. I've never been asked that before. At that stage, I just wanted to kind of hear about the birth, and kind of just that first week, really. That's as far as I could see forward. I did not want to hear about orthopedic issues and, neurology issues and pulmonology. I just wanted to hear about what was right in front of me, which was getting to that finish line, getting a healthy baby out and making sure she's okay in those first few days. That's all personally I was able to mentally handle at that moment in time for me.
Thank you, Professors Monica and Blakemore, and thank you, Ms. Kudner. This has been a very enlightening discussion. And again, thank you for participating. Hello, my name is Dr. Janet Laguerre, and I am a professor in the Department of Pediatrics at the University of Wisconsin in the USA. I am joined today by Dr. Klaus Monica, a professor of pediatric endocrinology in Germany. We are also joined by Ms. Carly Kuttner, the parent of a child with achondroplasia from New Jersey in the USA. Welcome, Carly. We are delighted to have you with us today. In this section, we will be considering the question, why is monitoring and early treatment in achondroplasia important in reducing the risk of pediatric complications? So we would like to discuss the need for multidisciplinary care and some of the recent guidelines that have been published, even extending that care into adulthood. Dr. Monica, could you please elaborate on that?
Yes, thank you. I think this international consensus statement is more an experienced statement, and we need, I think, now also data in the next 10 years or so with a new treatment. But as a starting point, it was very necessary to have these international guidelines that, for example, in the infancy, all infants should be referred to a skeletal dysplasia reference center or an HCP, so a healthcare provider with expertise in achondroplasia, as soon as a diagnosis is made. And I think this comes from the observation that when the parents, and Carly will confirm this, comes to the doctor, then they have a lot of questions. And for these questions, it's necessary really to have an expert and not simply someone who was studying medicine. For example, the other recommendation, all children should receive regular follow-up by an MDT. guided by an HCP with expertise in achondroplasia means almost the same, that when you started and you see this doctor, then you have a few questions, and when they are answered, you forgot a lot of them. Then you need really repeatedly to ask these questions, and the families, I think are really happy when they have a contact which are giving the expertise.
Carly, what has been your experience with the multidisciplinary team where your daughter is seen?
So I mentioned earlier we had switched hospitals at 10 months old. The first experience was not great. It felt very disconnected. But the second one was to a skeletal dysplasia clinic, and there we were met with just an incredible team. So it was led by the genetics department and their assistants, which were and are my point of contacts. I can get them on the phone or via email, really within an hour of any day, which is wonderful. Our team is made up of a neurologist, a pulmonologist, an ENT. Early on, it was speech and feeding team that we had for Mira, but that's since fallen away. And trying to think if I'm missing anyone, or orthopedics, of course. So orthopedics is a big one.
Thank you for explaining that. I'm going to talk a little bit about growth charts, and I'm hoping that your daughter has always been plotted on achondroplasia growth charts. It is very important to know that growth is a general marker of health. So it is important to always plot a child's growth on the appropriate growth chart for their condition. There are growth charts specific for achondroplasia for weight, height, head circumference, weight for length, BMI, waist, leg length, foot length. The most important ones are obviously going to be height, head circumference, weight for length, and BMI. Plotting a child with achondroplasia on a chart that is not for a child with achondroplasia really doesn't tell us anything regarding the health of that child. So it's really imperative that the appropriate growth charts are used. These are now in many of the medical record, the electronic medical record systems. And in cases where they're not in the electronic medical record, it's important to have these available on paper. So, Carly, was your daughter always plotted on the achondroplasia growth charts?
Yes. So to answer your question, Mira was always charted on achondroplasia charts. It was explained to us very early on that, the difference in the charts. And, we were shown with the head and the height and the weight, how it worked, how that translated locally to our local pediatrician. Thankfully, we have a great communication system where, I mentioned every time Mira goes to her geneticist, which is twice a year, all of that information, including the growth chart, is then given to our local pediatrician. Our local pediatrician has never tried to measure her. He weighs her, of course, but has never tried to measure her height. He knows that her other doctor will be in charge of that. And they've given that chart to this local doctor just so he has it on record.
And Dr. Monaco, would you care to elaborate on the role of bone age assessments and emerging tools for assessing growth?
Mm-hmm. Yeah, I think this is very important. But maybe I can mention also to Carly, one problem is always the obesity, and the children's doctor always tell you your child is too obese or whatever. But if you look for the growth charts and the BMI, then you can see your child is within the normal limits. So we need really these kind of growth charts and specific BMI charts. But come back to the bone age. bone age is also something different when you have a child which is healthy otherwise, has normal proportion, and they have normal bone. But in achondroplasia, you have dysplasia, you have dysplastic bones. And to calculate the bone age, that means the bone maturation, it's really necessary to have it very experienced rater. And this is not usually possible. And for this, we developed with a group of artificial intelligence engineers a tool which is called Dysplasia. Dysplasia means you can really measure the bone age, so the bone age maturation, also the bone maturation with an artificial intelligence tool. And this is published recently. And for the treatment with medical treatment, for example, it is necessary really to have this bone age to tell how long the treatment is possible. So when the bone age is whatever, 12 or 13, it would be for a girl a very, very late time of starting treatment. But if the bone age in this 12-year-old girl is 10 years or 9 years, then you have a longer period of 5 or 6 years for treatment. So for this, bone age is really, for pediatric endocrinologists, always a very, very important figure to decide.
And thank you, Professor Monica. I couldn't agree more when it comes to the weight for length and the BMI issues. We have patients who come in and are told that they are obese, but when you put them on the correct chart for achondroplasia, they are in the 30th percentile or the 40th percentile, which is very, very healthy. As we're talking about other assessments, it is also very important to keep an eye on functional abilities. So talking about development, how did children develop? How are they able to do things? Are they finding that they can walk the amount of distance that they want, that they can participate in childhood activities that they would like? And there are new tools for assessing abilities in children with achondroplasia, and those also play an important role in the clinical follow-up. Carly, do they ask you questions specifically about your daughter and how she is able to do things and play with her peers when you go in for your clinical appointments?
Yep. Yes. Every time, now that she's 7 years old. So we definitely were asked what kind of activities she's involved in, and can she keep up with her friends? How she maneuvers around her school. Does she complain of any pain? We're asked a ton of questions during our visit to see where she's at.
So there's an increased risk of spinal claudication and spinal stenosis as children age into adulthood. So it's important for people to always be monitoring this. As we talk about transition to adulthood, it is important to know that in different countries, there may be different systems. And even in the United States, different clinics may have different policies. But it is important that even in adulthood, that patients with achondroplasia continue to be followed by a specialist. Well, thank you, Professor Monica and Ms. Kuttner, for joining us today. This was a very enlightening discussion. And again, thank you for being with us.
Hello, my name is Karen Blakemore, and I am a professor of gynecology and obstetrics at Johns Hopkins in Baltimore in the United States. I'm pleased to be joined today by Dr. Klaus Manneke, who is professor of endocrinology in pediatrics at the Children's Hospital in Otto von Guericke University in Germany. Welcome, Professor Manneke. I'm also joined by Dr. Janet Laguerre, who is a clinical professor of pediatrics at the University of Wisconsin in the United States. Welcome, Professor Laguerre. We are also pleased to be joined by Ms. Carly Kuttner. She's the parent of a child with achondroplasia from New Jersey in the United States. Welcome, Carly. We are delighted to have you with us. In this section, we will be considering the question of the impact of pharmacotherapies in maximizing life goal attainment through guideline-based management. I would like to start with Professor Laguerre in terms of the role of pharmacotherapies to support the desired outcomes.
What we know is that the medical sequelae result from which bones are affected. As we progress through clinical trials and we obtain more data, we are learning that earlier treatment with these interventions is much more effective. A recent study showed that the area of the foramen magnum and the area of the sinuses was increased in children who started interventions before 6 months of age. The goal of all of these therapies is to decrease medical sequelae and improve quality of life. Yes, they also increase height, and that will help with increasing function, increasing quality of life in the fact that you can be able to reach things better. But the other goal of these therapies is to decrease sleep-disordered breathing, hopefully decrease the need for foramen magnum decompression, perhaps decrease the need for ENT surgeries, and decrease the need for orthopedic surgeries in the future. Again, we don't have data on all of this, but that is the hope. What we do know is that we want to intervene while bones are still growing. And bones are still growing when children are very young. And so to get the most medical benefit, these medications really need to be started early and be utilized effectively prior to those bone growth plates starting to close.
Yeah, I think it's always the problem with the bone age. The bone maturation limits the time when we can treat for the length of extremities. So I agree, as early as possible. And in Europe, we have the possibility to start at age 4 months. In the US, I think at birth. But to start after beginning of puberty is also possible. If the child already is now 13 or 14 years and has bowing legs, then the bowing legs have to be operated. And the easiest operation surgery is the 8-plate surgery. I don't know if you know how what is this 8-plate means. Is you can really stop the bowing of the legs with as long as the child is growing. So if, for example, the child has 12 centimeter knee distance, then you can even in a 13, 14-year-old child treat this child with the drugs, and you can decrease these knee distance. But summarizing, as early as possible is the best way to treat.
And may I ask, if the treatment is started in infancy, does the leg bowing tend to not appear as readily?
If you treat early, at least you can increase the height of the tibia, which means you have the chance that the bowing is not so bad.
I would agree with that, is that when we have started earlier, we have anecdotally seen less bowing. However, we don't have any objective data with large groups of patients that can confirm this.
That's very interesting. Carly, would we ask for your own experience with initiating treatment for Mira?
Sure. So this type of treatment was not we weren't informed of it when Mira was an infant, even though it was in clinical trials at the time. It really didn't hit our radar till she was about 3 years old. And at the time, it wasn't available until you were 5 years of age to receive. So it's something that we had in the back of our minds, but until she turned 5, it wasn't really a reality for us. But we knew that giving Mira any chance at a better quality of life was something that we were very much interested. And so we started the treatment of a CNP analog when she was about 5 years old.
Well, what has been the impact of these pharmacotherapies on the clinical outcomes and life outcomes for the children that have gone on to these therapies? May I ask you, Professor Laguerre, as to what have been the results thus far?
So the most data that we have is about height. And people that were on the CNP analog, they gain on average an extra 1.57 centimeters per year over people that are not taking that medication. There are other clinical trials that are out there, and another CNP analog, but a weekly injection. Those patients also gained approximately 1.5 extra centimeters over baseline growth. Another trial that is an oral medication that blocks further up in the pathway in achondroplasia, those patients gained an average of 3 extra centimeters. But I think we need to be cautious with that data. It was based on a small number of patients and only over 6 months of time instead of over a full 12 months of time. So all of these clinical trials are still ongoing. Recently, at the American College of Medical Genetics, there was data presented that showed an higher quality of life scores in patients who had taken the medication. Now, how to interpret those is really questionable. We don't know yet. We don't have that objective data yet.
Very good. And Carly, could you comment on Myra's treatment, her experience, and any outcomes that you can share with us?
Sure. So the treatment itself has been fine. She's just responded very well to it. We've thankfully never had any type of negative reaction to her physically at all. So we feel very comfortable in it. In terms of her results, so as I mentioned, it's been just over, in March would be 2 years. So it's just over 2 years of treatment, and we have seen an improvement. She has been measured every 6 months by her genetics team, and she has grown on, again, everything's based on averages, but an additional centimeter and a half over her height prior to using the medication. But more importantly than that, as parents, we see her growth in other ways. So the things that she's able to do, the things that she's really just able to reach, countertops, and she's always been wanting to reach up on certain things in our home, and she's able to now without a stool, which is wonderful. She's able to, take care of her clothes on and off, and getting on and off the toilet and cleaning herself independently. This wasn't something that she was able to do even a year ago. So it's been a huge step forward for her. As a mom and as a woman, something I'm excited about is that some of her clothing does not need to be hemmed anymore. So there's a picture here of her in her rainbow dress from a Taylor Swift event she went to at school, where I actually did not have to hem the dress 6 or 7 inches up. She just wore it right as is off the rack, which was really exciting. Here's a picture on the left of her. This is a new hobby of hers, is roller skating. And with the help of they call it a skate mate, is the thing she's holding on to. It's something that she loves doing. She begs me to go roller skating all the time. And she's just able to do it for, an hour or two. She goes nonstop, which is wonderful. This is a picture of it's a seated scooter, but you can see my very innovative husband mirror-proofed it, is what we call it. So he added that hot pink back kind of pillow made of duct tape and some PVC pipe handles. And she was not able to reach where the feet go a year or two ago, and now she's able to very comfortably reach those pedals. So she's able to scoot around with her older sister, and she just, again, it just makes her feel so much more confident and independent that she can do it like her big sister. So it's a huge win for her and for us.
Well, she certainly looks like she's a very active lady, and nothing's stopping her. Maybe we can turn to some of the updates from the latest trial readouts, which we've touched on a little bit, but from the ACMG presentations and latest data for our current and then our future management.
Sure. At the American College of Medical Genetics, the data was shown that patients who started the medications under age 2 grew at an average of 80% of that of average stature children, whereas usually children with achondroplasia grow at approximately 67%, or 2/3 the rate of those of average stature children. In children who started the medications after age 2 and were on it for 4 years of treatment, they grew at an average of 90% the rate of average stature children. Now, this is important because these children are keeping up just a little bit better, and that can help with leg length, arm reach, independence, as Carly was mentioning. So things as simple as dressing yourself, being independent in the bathroom. These are life skills that people in elementary school want to be able to do. They want to be able to be independent. And this study was shown with the CNP analog data, which is given every day. Again, there are clinical trials for a weekly CNP analog, as well as for infigratinib, which is a tyrosine kinase inhibitor, which is oral.
Yeah, I think it's interesting, and I can also mention this thing on proportion. Before the last years, we were seeing no effect on proportion, but now when these studies are going on, we can now see there is an improvement in proportion, and I think this is a major impact.
Professor Nogueira, if I could ask you, what is the safety profile thus far for these CNP analogs and the kinase inhibitor?
Thank you for that question. The CNP analogs are very specific to a particular pathway, and overall the safety profile is quite good. They do interact with natriuretic peptide, which can cause decrease in blood pressure. However, in the long-term trial data, there was this potential decrease in blood pressure was mitigated by giving the medication after eating and drinking. And in the trials, nobody dropped out of the trials because of low blood pressure or had symptomatic episodes of low blood pressure. Theoretically, the safety profile of the tyrosine kinase inhibitors is a little bit broader because these tyrosine kinase inhibitors block more of the pathway. So theoretically, they will have the potential to have more side effects. However, again, in the phase 2 trials, nothing of significance was found. They found one patient with hyperphosphatemia, but when the dose was decreased, that resolved.
I asked Carly again, if you could tell us what your hopes would be for future trial designs, future treatments, and for the achondroplasia community in general.
Sure. I think that, if I could build something perfect, it would be a more convenient, less frequent delivery method. Currently we're daily, so that would be something a little less frequent. Would be nice. I think accessibility. My hope would be that the entire world would have access. The whole global achondroplasia community would have all of the access and all of the information. Just the more information, the better, I think would be my hope for everyone.
Wow, I think we could all agree on that. And I want to thank you, Carly, and Professor Laguerre and Professor Monica very much for updating us on these very important and interesting clinical trials that are currently ongoing.